my name is Jeff Kerby, otherwise known as Surgeon A, the knuckle-dragging senior trauma surgeon that does everything open from Dr. Porterfield's talk. It's good to be here. I recognize a lot of old friends and people that we work with on a daily basis. So my task was to talk about changing paradigms in blood utilization. I don't know if I really have changing paradigms. We are big utilizers of blood on the trauma service. Not because we create a lot of bleeding, but we have to stop a lot of bleeding, and we have to replace a lot of what's been lost. So a lot of the focus of blood utilization and blood management programs in the hospital are focused on our service because we use so much of the blood. So this is what we're going to talk about today, blood utilization at UAB. We'll kind of give an overview of what kind of blood products, what volume of blood products we use. We are a big user of blood products on the trauma service, and we'll talk some about that. We'll talk about some new approaches for bleeding control. If you really want to control the amount of blood that's being used in the hospital, you need to stop bleeding as quickly as possible, as close to the point of injury as you can, so you don't have to replace as much blood as we are right now. We'll talk about current approaches to resuscitation for massive hemorrhage. That has changed. There are new paradigms out there. Unfortunately, we have been at war or in conflict for a number of years. It's unfortunate, but if you're going to go through that, you need to learn as much as you can about how to better take care of combat casualties, and that's what we've done. And it's now has changed the way we resuscitate patients in the civilian trauma world as well. We'll talk about some of that, but some of that has changed the way we look at blood utilization, blood use in these resuscitation protocols, and we'll talk some about that through this talk. We'll end up with the effect of blood age on mortality. Right now, the storage shelf life of a unit of blood is 42 days. There is some concern, and we have some data that shows that as that blood gets older toward the end of its shelf life, it may cause some problems with patient outcomes. And if you think about it, it's sort of like the dairy section in the supermarket. It's the oldest units of blood or the oldest milk is sold first. The other stuff's way back in the back. And blood banks love traumas because they can unload a lot of their old inventory real fast. So the trauma patients tend to get a lot of the older blood, and we'll show some data on that. So if we look at blood utilization in UAB from 2009 to 2016, you can tell we used a lot of blood at UAB, anywhere from 29,000 to 32,000 units. I think before 2009 and the era preceding that, we were using at one time about 40,000 units of blood a year at UAB. I think we were the second largest user of blood in the country at UAB. This is before we really focused on blood utilization. We set lower targets for triggers for transfusion. We don't automatically give 2 units of blood now. And as a reflex, we really think about that, try to give 1 unit at a time, and it has decreased the amount of blood we use over time. If you look at who's using the blood at UAB, trauma is the biggest culprit of that. I don't know how this thing works. Does this work? Oh, never mind. Okay, well, the TBU is the trauma burn nursing unit. The TBICU is the trauma burn ICU unit. You can tell we use about 4,000 units of blood in those units every year, about double the other ICUs in the hospital. Again, we have a large need for blood and blood products. We're not proud of this, but it is what it is. It comes with the territory. It's what we do. If you look at the top nursing units with blood utilization, the ones highlighted in yellow are the ones that we own, the trauma burns intensive care unit, trauma burns nursing unit, the SICU, and the acute trauma care unit. For the top 8 nursing units on trauma have the highest use of blood products in the hospital. So this is a big focus for us in our trauma service. We do use a lot of blood, and we're looking for strategies to try to decrease that usage over time if we can. If we look at the causes of potentially survivable deaths, this is military data. This is from October 1st to November 4th. They looked at 85 of those deaths, and as you can see, hemorrhage, either compressible, which is a pre-hospital target, we'll talk a little bit about that in the next few slides, or non-compressible hemorrhage accounts for about 79% of the preventable deaths. When you look back at the case, which cases are potentially survivable, which are not, it makes up about 80% of the potentially survivable deaths. So it really is a focus in trauma care and how to prevent hemorrhage, how to prevent blood loss to improve survival. That's military data. This is civilian hemorrhagic mortality data. Most of the deaths that we see happen in the pre-hospital environment before they even get to us, and about 35–40% of patients die of hemorrhage before they even get to the hospital to be cared for. It also, in the first 24 hours, is a major cause of mortality. It is the highest cause of mortality overall in our trauma population. Civilian bleeding to death is an acute problem. It happens early. An earlier control of hemorrhage should save lives, and that's really where a focus of a lot of work going on right now is. And this is a pretty typical scene in our trauma bay, in our OR. You see a lot of blood on the floor. You see a lot of used blood units stacked up in the corner. But if we could somehow do something to prevent all this from happening, the spillage of blood, the loss of blood, and if we could do this and apply this early in the field, we might be able to prevent some of this blood utilization that we have. So the Hartford Consensus is what has resulted from an increased effort to understand how we can improve survival after an active shooter or mass casualty, intentional mass casualty event. This really started after the Sandy Hook Elementary mass casualty active shooter event. This is called the Hartford Consensus because it started at Hartford Hospital. A trauma surgeon named Linwood Jacobs really pushed this and started this. But he convened a group of trauma surgeons to really try to look at this and figure out how we can prevent deaths. And if you look back at the preventable deaths from some of those events, and there have been a number of events recently, so I think this is going to become, unfortunately, part of the norm. It's not if, it's when, and we need to be prepared for when these events occur to save the most number of lives that we can. But when they look back at the potentially survivable deaths, most of them were extremity injuries when patients bled out from extremity injuries. So one of the big focuses right now is really trying to educate the public, really make this as ubiquitous as CPR training, to teach the public how to use a tourniquet to stop bleeding. So there's a lot of these Stop the Bleed campaigns. They put together these Stop the Bleed kits that are being deployed in schools, in factories, in places where there might be mass casualties or issues or problems, and teaching everybody how to apply a tourniquet so that they can potentially survive. If you also look at the recent Orlando shooting, that place was not secured for 2 hours. First responders could not get into the nightclub for 2 hours to provide care for those patients. So the only way that could have been prevented is if they had some of these kits there, or if you carried one in your pocket, people knew how to apply them. So bystanders or minimally injured casualties could help apply these tourniquets and potentially save a lot of lives. REBOA, resuscitative endovascular balloon occlusion of the aorta. It is not a new technology. The picture in the upper left-hand corner is from 1954. There was a lieutenant colonel in the Army who actually used this in 2 combat casualties in the Korean conflict. Reported on it. The outcomes weren't good. They both died. But certainly it was an interesting concept to thread this balloon up through the femoral artery into the aorta, occlude it, and stop bleeding. It went away for a while and has now had a resurgence with some new research now emerging. They've really engineered these balloon catheters so that they're more practical for use in the ED as well as in other places, which I'll show you here shortly. But the idea is simply to, if you have a patient who's bleeding, real quickly access the femoral artery, thread this up into the aorta, and depending on where the bleeding is, measure it, put it in place, and divert blood flow back to the heart, back to the brain, and prevent the loss of blood. Now, we typically think of this as being placed in the emergency room. However, people have taken this to the field. On the right-hand side, this is Gareth Davies. He's a physician. He flies on helicopters in London. Okay, and in other EMS agencies outside of the United States, doctors sometimes ride on ambulances Doctors sometimes ride on helicopters and go to the scene to care for patients. So he has actually placed one of these catheters in a field setting and has it is a technology that they take to the field in London. On the left-hand side, this is a picture that I borrowed from Dr. Manley. Dr. Manley's going to talk next. This is Dr. Manley. Dr. Manley is an active duty Air Force surgeon. We are very honored to have 3 special operations surgical teams stationed at UAB. They work with us. They're on staff. They have clinical privileges. They train with us, and then they deploy to take care of our active duty military when they are deployed in war zones. It's a 5-member team. They go close to the front lines, set up a operating room of opportunity. But Dr. Manley was the first active duty military member to use Reboa in the field. He's got a case series of 4 patients now, but this was the first military use of Reboa ever. And all 4 patients survived to leave the field hospital alive. So we're looking at this technology. This is a very useful example of how a military-civilian collaboration not only helps the military, it can help a civilian hospital. We've not been an early adopter of Reboa. We've been waiting for the engineering, the technology to get a little bit better for us to develop protocols, but now we have somebody who has real-life experience using Reboa who can help us integrate that into our practice here. So it's a nice collaboration that we have with the military in our civilian hospital. And I think you'll see these military-civilian collaborations grow and expand over time as there's now increased effort and interest from the military in placing active duty surgeons in in civilian hospitals. This is Dr. Manley's experience. He's been asked to, as you might expect, to give several talks about his experience with using Reboa in the field. So this is how we used to resuscitate patients with the standard resuscitation paradigm. We'd give a lot of the clear crystalloid stuff. We'd give a few liters of that, see if they responded or not, give them blood, wait a little bit. We might think about giving FFP. We'd give a lot of blood. And then later on we might think about, oh, we should have given some platelets and give some platelets. Okay, this is how we used to do things. The military, through these recent conflicts, has really pushed this idea of giving a higher ratio of blood and blood products early on and trying to eliminate as much crystalloid as possible. Really, the idea is trying to replace what they've lost and not dilute it out with crystalloid. It lowers the pH, it dilutes clotting factors, it makes you cold, it makes you more coagulopathic. Really give blood and blood products, really try to reconstitute whole blood early on. And this is sort of the way we approach it now. This is called damage control resuscitation. Hypotensive resuscitation really happens and starts in the field. It's not something you actively try to do, but you allow patients to be a little more hypotensive. You don't try to give them a bunch of fluid, jack up their pressure, pop the clot, and cause more bleeding, because you don't really have anything to replace it with that can carry oxygen. So let them be a little hypotensive, limit crystalloid resuscitation, and get them to the hospital as quickly as you can. Once in the hospital, we can quickly assess the patient. Sometimes by clinical gestalt, you just know that they're going to require a large volume blood transfusion. There is also some scoring mechanisms you can use to predict those who might require a massive transfusion protocol, and you give products in a high ratio of blood, FFP, and platelets. Some use a 1-to-1-to-1. Most use 1-to-1-to-1. We're sort of between 1-to-1-to-1 to 1-to-1-to-2 with our massive transfusion protocols. But this is what we do currently. So we're giving a lot more blood up front to these patients than we used to, limiting the crystalloid resuscitation that they get. And we think it improves survival, increases the ability of the patient to clot, so on and so forth. So it's hypotensive resuscitation. This is damage control resuscitation, 2 components, hypotensive resuscitation, and then this hemostatic resuscitation. Hypotensive resuscitation, as I said, begins in the field. Avoid popping the clot. Get them to the hospital as quickly as you can. In the hospital, we limit crystalloid resuscitation and really give high ratios of blood, plasma, platelets up front very early on. It's got a long history in the military. The idea is to minimize further bleeding by preventing the popping of the clot. This is not a new concept. This was a concept that was pushed forward in the early 1910s, back in World War I, that you don't want to jack up the pressure, pop the clot, and cause more bleeding. A civilian study did show efficacy. There was a study in Houston looking at penetrating trauma with a delayed resuscitation. Based on the day of the week, they randomized patients to no resuscitation versus standard resuscitation, and the no resuscitation group actually survived at a higher rate. There has been a follow-up study that we participated in through the Resuscitation Outcomes Consortium and blunt trauma patients as well that has shown a trend toward improved survival. We've shown it's feasible, we can do it. We need to do a larger study to validate the results, but you can allow the patient to be hypotensive, minimize crystalloid, and the patients do just as well or better. For damage control resuscitation, again, we try to minimize crystalloid, transfuse those components at a high ratio, and then provide expedient hemorrhage control. And those two adjuncts we talked about, the tourniquets, the Riboa, might be able to help us prevent the further hemorrhage control, and they may be able to be applied early on, closer to the point of injury, and prevent large volume blood loss that then needs to be replaced. Get them to the OR, get them to IR, stop the bleeding however you can, as quickly as you can. Again, the recent conflicts provide us a large number of patients to learn a lot from. This is actually a slide that I borrowed from J. Joe Hanneman, who's in Cincinnati with Dr. Pritz. He is a reservist in the military, deploys a lot in support of these operations. And in a short period of time, from January to May, January 2004 to May 2005, they had 4,493 trauma admissions. 23% required a transfusion, much higher than the civilian experience. 243 required massive transfusions, which was defined as greater than 10 units in a 24-hour period. Again, this is about twice the civilian experience, so you were able to accumulate a bunch of patients real fast and learn a lot from them. And a mortality in patients requiring massive transfusions is about 25.4%. That's about equivalent to what it is in the civilian experience. So they looked back at these in a retrospective chart review, looked at 246 patients that got the massive transfusion. They compared survival at 24 hours in 3 groups based on the plasma RBC ratio that they got. If they got a low ratio, a medium ratio, or a high ratio, and looked at outcomes. And this is what they found. If you got a low ratio, your mortality was extremely high. If you got a higher ratio, then the mortality decreased accordingly based on the ratio that the patient received. Now, there was some problems with this. It's retrospective. There's a lot of bias in this. We published a paper talking about survival bias in this type of analysis. But still, I think clinically, based on this paper, a lot of people changed their practice based on this single retrospective review. The other thing that really helped us out was the availability of thawed plasma. So just automatically, by the availability of thawed plasma, we gave higher ratios of blood to plasma. We have massive transfusion protocols in place at UAB, as most centers do now. Basically, our kit has 6 units of packed red blood cells, 40 units of thawed plasma, and a 6-pack of platelets. It's activated by physician order. You can call us the blood bank. They've got the blood on racks ready to go. They put it in there, and we can have it in the ED in 4 minutes from the time we call. So we can get a large volume of blood and plasma we can transfuse in high ratios very quickly this way. And if you worry about us using more blood because of a protocol like this where we have blood products readily available to us, that's not true. A couple of nice papers from Brian Cotton have shown that the use of these types of protocols actually decrease blood volume usage because you resuscitate the patients better, they clot better, they stop losing blood, okay? So not increased usage. We're actually pushing blood, talk about blood utilization, trying to get it out there as quickly as far forward as we can. We're actually using blood in the pre-hospital environment as well. I'm the medical director for Lifesaver 2 based out of Rainbow City, and we're starting to deploy blood on those helicopters. There's a lot of studies that have shown that there's not a lot of blood product wastage doing this. The nurses that are on the choppers are very good about determining who needs blood and who doesn't. So there's not a lot of misuse of the blood products, and we can set up a very nice blood management program to cover this for our chopper system. So you're going to start seeing this in Alabama now very soon. I think actually Huntsville already has blood on the choppers up north. So studies have looked at this. This is a study from Memorial Hermann Hospital comparing air agencies with and without blood, and basically the bottom line is the outcomes were improved in those patients. So that gives us to blood age, effect on outcomes. Again, as I said, it's like the dairy section. You know, oldest units or oldest product out first, newer bloods in the back of the shelf. And trauma gets a lot of that because we take out of a lot of inventory, old inventory, very quickly. And big places like UAB get some of the older inventory because they know there's high turnover at a place like UAB. So it was really a concern for us. And we looked at this in this paper that we published in 2010, looking at patients who received older blood, and blood bankers don't like us to refer to blood as old. We like to consider it stored versus fresh now because old has a negative connotation. But anyway, in this study, we defined it as greater than 14 days, greater than or equal to 14 days. And if patients transfuse greater than 3 units of old blood within 24 hours of hospital arrival had a higher mortality with a relative risk of 1.57 in this paper that we published. Now, there are several different mechanisms for this. We looked at this in the lab, looking at erythrocyte red blood cell storage and increased rates of NO and nitric oxide scavenging. And also clinically, we could see that giving older units of blood caused a microvascular response and actually decreased capillary perfusion at the microvascular level in patients who received the older units. This is a paper that is currently being submitted, looking at our own experience with massively transfused patients in Alabama. And if you look at patients who received the older blood in our massively transfused patients, we saw an early mortality signal. Those patients who received the mostly stored blood had about a 2.5 times higher crude relative risk and a 2.74 times adjusted risk of mortality than those who received the mostly fresh blood. So there does seem to be a signal there. Now, is this a problem? This is a paper that put together by Allison Jones in our nursing school, looking at all of these centers that participated in the proper trial. And a proper trial was a trial put together that looked at different ratios of blood product transfusion and mortality. There were 12 centers that participated, and we just looked to see how much old blood was being given to massively transfused patients. And as you can see from the slide, at least 3 centers, over half, right at half or over half of the blood that was given was older than 21 days old. So there is a potential problem out there at some of our trauma centers with the use of older blood and potentially use or deleterious outcomes based on that, if you believe the research that's been done. So we need a proposed multi-center trial. You know, there's been a lot of studies published recently, large multi-center studies looking at the age of blood and the effect on outcomes in patients in the ICU and in the general hospital population. Most of them have shown that there's been no mortality difference. But however, the big difference here is that in those studies, mostly, they got only a couple to 4 units of blood. Okay, in our massively transfused population, some of these patients are getting their entire blood volume replaced. So a lot higher. So we really haven't answered the question in the trauma population, does giving old blood affect outcomes? And certainly we need a clinical trial, and we've developed a clinical trial, a stratum trial, which we're trying to get funded and begin hopefully in the next year or 2. So in summary, trauma care requires a lot of blood. New interventions are aimed at decreasing blood loss with tourniquet applications, and we're out there trying to train as many people as we can and get these tourniquet kits out there in places where they might be useful. Roboa is a new emerging technology that we're going to implement here shortly. Resuscitation protocols utilize blood and blood products earlier. A higher ratio of blood product transfusion is given now, and we're putting blood out in air with the air agencies. And then data suggests worse outcome in trauma patients receiving older blood, and we need a clinical trial to really evaluate that to see if it really has an effect. And this is a slide I always end with. This reminds me of who the real heroes are in our trauma system and care for trauma patients, which are our pre-hospital providers who do a lot of the heavy lifting taking care of these patients. So with that, I'll end, and thank you for your attention. Thanks.